All right, everyone, why don't we go ahead and get started? Thank you for joining us for this very exciting webinar this morning or afternoon, depending where you're at. Caregiver identification, strategies for advancing person-centered dementia care across settings. We're just thrilled to be presenting this as a joint webinar. Our Bold Public Health Center of Excellence on Dementia Caregiving is collaborating with the Bold Public Health Center of Excellence in Early Detection of Dementia. Given the topic of interest and really the breadth of importance we believe caregiver identification has when we consider the public health ramifications, not just of dementia caregiving, but of dementia in general. I'd like to begin with a land acknowledgement. The University of Minnesota Twin Cities is located on traditional, ancestral, and contemporary lands of Indigenous people. We acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor the traditional cultural Dakota values, courage, wisdom, respect, and generosity. We hope that all of these values are abundantly evident in, again, this wonderful group of presenters and presentations today. So real quickly, our Public Health Center of Excellence on Dementia Caregiving, and certainly Dr. Chodosh and Dr. Borson can share more details about their particular center as well. The Public Health Center of Excellence on Dementia Caregiving, or the PICO-DC for short, designed to support state, tribal, and local public health agencies in really not only developing information, but disseminating tools and resources to best support unpaid caregivers of people living with dementia. And you see some of the ways we intend and are accomplishing this really, I would say, ambitious but exciting mission. Improving improving access to evidence-based programs, facilitating connections and collaboration with public health agencies and other key partner organizations, and then also providing technical assistance. If your agency or organization is working on something related to dementia caregiving and you feel our center can be of assistance, we really encourage you to reach out to us, and we are excited to help you because, again, a major emphasis of our center is to provide technical assistance. Really thrilled with the presenters that are willing to join us here today, several of which are really close colleagues whose work I've respected for many, many years. We'll have Dr. Alan Stevens with us. He is the co-chair of the Raise Family Council, which I believe many of you are familiar with. He is an endowed chair at the Texas A&M Health Science Center, as well as Baylor, Scott, and White Health. I have long admired Dr. Stevens' work and really thrilled to have him here with us today. We also have Juliana Valencia from Fairfax Area Agency on Aging, Fairfax County Area Agency on Aging. Ms. Valencia is part of an award-winning team that has really done some innovative, novel work in not only identifying caregivers, but using that identification process to link caregivers to needed services. And we're excited to hear more about that. We also have Kristen Griffis with us, CEO of Elder Options in Mid-Florida, again, Area Agency on Aging, and again, an award-winning agency that specifically is really partnering closely with a local healthcare organization to, again, get at this issue of not only identifying caregivers, but then linking them with the services needed, as well as, quite frankly, operating as a deliverer of said services. And then I mentioned them already, again, very close colleagues, people whose work I respect so much and are preeminent in their fields and in the fields of dementia care. Dr. Sue Borson and Dr. Josh Chodosh, these are the co-directors of the Public Health Center of Excellence on Early Detection. And again, we're thrilled to have them here. They will be providing their reflections, thoughts, and really helping us synthesize a lot of the great information presented to you here today. So again, if you have questions and or you have questions specifically that you'd like to pose to the presenters, I recommend and ask that you utilize the Q&A function on your Zoom toolbar. And throughout the presentation today, either I or the speakers themselves will be addressing these questions. But again, in all likelihood, I'll probably serve as the quasi-moderator here today, which I'm more than happy to do. The other thing I'd ask you to do is, if your program is doing exciting work, if your program is doing interesting things around caregiver identification, identifying, assessing caregivers, however you define that and conceive of that, please share that in the chat as well, as I think many of us would like to learn more about what you're doing as well. And again, using this webinar as a platform for connection and collaboration. With that, I'm going to turn it over to Dr. Stevens. And again, thank you for joining us here today.
Thank you so much, Joe, for that kind introduction and for this invitation to be here today. I'm delighted to be able to share some of my thoughts on this very important topic. Okay, so hopefully you're seeing my slides now.
Looks good, Alan. Thank you.
Oh, okay, great. So thank you, Joe, again. I am both associated with Baylor Scott and White Health, which is a large integrated healthcare system in Texas, and with the Texas A&M Health Science System. My role today is to really do a little bit of stage setting, I think, for why this topic is so important. And for many of you, this will be, yes, maybe a yes and a course moment, that these are what we know and live with every day. But I do think it's important for us to look at where we are now in the process of really pushing the idea of caregiver identification and why we're to the point where we no longer should be justifying this. We should be taking action on it. And so a lot of what I want to do or I strive to do more from my policy work is to push that envelope into beyond the conceptual benefit of identifying family caregivers to the point of this is the actions that need to occur. So just very historical mention here of family caregiving has really emerged with quite a great importance in recent years. Many on the group will know this from their work in the field, the research they have contributed to the field, the policy making they have influenced in the field. But we can't deny that as a consumer group, caregivers are starting to exert themselves more. And I say largely in the term consumer group, and that also means in the workplace, in the marketplace, all of those areas of society that we now see family caregivers being represented more and making their needs more known. And of course, in the healthcare community, I think we have been slow out of the gate, perhaps, on this topic. But now, as we look towards more innovative care, particularly in the realm of dementia care, we can't deny that family caregivers hold a really strong position in any kind of innovations that we want to move forward. I do think this is a nice union with the emphasis on social determinants of health, that we also see the healthcare organizations to be growing in greater and greater interest of, not from the now moving even from the point of, hey, these things exist, we've always known they are, to we can measure them, now even to the point of saying, and now we have to act upon them outside of the traditional healthcare arena to minimize the impact of negative social determinants of health. And I think with that perspective, it makes the family caregiver shine even brighter when we start to look at what is the individual social determinants of health. And let me just quickly say that in many cases, the social determinants of health for an individual may be fairly robust and of benefit to the person, the older adult receiving care, if the family caregiver is in place. Remove the family caregiver, in any way that can happen, and we know it can happen in many different ways, the person's social determinants of health crumble. So we have to look at the importance of family caregivers in numerous ways and understand that they are the key to healthcare innovation, and I should say healthcare delivery innovation, partnerships and integration of medical models of care and social models of care. We keep coming back again and again where the innovation lies is going to be largely determinant on the involvement of a family caregiver. So starting back, probably now, 8 years ago, or 5, 6, 7 years ago, there started to be a greater interest in family caregiving with a number of reports that were then being commissioned by the National Academy of Medicine. One of the early reports is Families Caring for an Aging America. And that brought to light, I think, the impact of caregiving on families. And I think started to map out what we knew about caregiving, and most importantly, started to highlight things, topics which we had not previously placed much attention upon in the research world of family caregiving. And that in particular was interaction with healthcare organizations. Then independent of that, and you saw organizations like AARP roll out nationwide efforts directed at states to improve care transitions for persons with dementia and other older adults with the CARE Act. So this has process and interest in making care better has been developing, and there's been a growing base of evidence from very, very comprehensive and scholarly reviews of the literature. A second report that came out more recently, that of course Dr. Gaugler is very, very familiar with, is a report that looked at where are the strengths in terms of types of interventions that we can move forward to support family caregivers. And this very important report showed that there are many ways in which caregivers can be supported and many different efforts to do that. But really there's only looking at a very systematic review of the literature using very tight criteria. Two models of care kind of bubbled up to the top as being those that have had shown the greatest efficacy to date. And I want to focus on the first one, collaborative care models, which integrate medical and social models of care. These, by definition, involve electronic health records. And they involve the engagement of multiple people, team players, members of the healthcare team, are engaging in comprehensive plans of care that are often coordinated and communicated through electronic health records. So another emphasis here of we know what works, and what works requires good engagement of families in healthcare, not only providers, but families in healthcare records. An even more recent report from the National Academy of Medicine focused on the cost of care and the cost of delivery of care. And as it highlighted here, great emphasis being placed on not only the people living with dementia, but their families and their healthcare providers and other providers outside the formal healthcare setting. So again, the evidence continues to build in very systematic ways that have been done very rigorously and have the potential to drive policy. Earlier it was mentioned that I co-chair the Raise Family Caregiving Advisory Council, which came out of the RAISE Act. And this was an act of Congress that pulled together and mandated a group of both non-federal members, which I am one, and federal members representing key agencies within the federal government to do an initial report to Congress about the status of family caregiving, with the intent that this report would build or support the foundation of a national caregiving strategy. And again, I go back to being optimistic that we're to the point of saying, let's move into action because we know what people need. We know what works. It's time to move into a national strategy mode where individual sectors versus healthcare, families, payers, providers, and I say that both in the community side, AAAs who do such great work, are really come forward in a coordinated way that's structured by a national strategy. So we'll put this in the chat later, but if you can go to this site, there's this one is actually housed by ACL. There's tremendous information there. And there's also a link to a dissemination center housed at NASHP that also has very, very good information about the RAISE Act and stories from family caregivers. And let me just say that while the other reports are extremely well done and scholarly, our report to Congress builds upon that, but also takes the perspective of we wanted to hear from real caregivers. I like to personally say, in my mind, we were taking what had been pulled from the literature, what we had studied, what we had learned, and now taking it back to caregivers and saying, does this make sense? This is what the research says, but does this reflect your life? And we got a tremendous buy-in, a tremendous amount of input from caregivers from across the country. And much of these stories, including 25 very deep stories that are narrated in a video, are available upon the NASHP site that I spoke of earlier. So my point here is that you see now coming from a advisory council that was set up to work both with citizens, non-federal members, and many of us have had family caregiving responsibilities, and many caregivers represent not only older individuals with dementia, but also children with disabilities. And we identified 5 priority areas and then have made 26 recommendations to Congress. And it's upon these 26 recommendations that we will see specific strategies develop. I just want to pull out one of the 5 areas that we identified in our report to Congress. Because it fits so well with today is goal 2. Family caregivers are recognized, engaged, and supported as key partners with providers of healthcare and long-term services and support. So encapsulates a lot there, but in particularly, I want to recognize recommendation 2.2, which, as you can see, directly goes to the issue of family caregivers being essential members and partners in the health that a person with dementia receives. So I think there are multiple, in all 5 of these sub-recommendations, there are issues that would touch upon what we're talking about today. But in the sake of time, I encourage you to go to the website, read this report. There's more details about each one of them. But clearly, the case has been made now across many different sectors and now reported to Congress in a way that we hope will mobilize better caregiver identification. So what might that look like? And I'm going to be really quick here because I'm running long and these will be available to you later. Recognizing family caregivers and electronic health record is not as simple or direct as that might sound. There are many different types of electronic health records. And then once you're in an electronic health record, how information is inputted has a huge impact on how easy it is to retrieve information. So we have to think carefully about how do we not only get the information in, but how do we get it in a meaningful way that is clearly visible when it's needed. So here are a few points that I'll run through here. And here's a simple one, but gosh, I wish we didn't overlook it so much. A family caregiver is a unique role, and that person serving as the family caregiver may also be the emergency contact and the healthcare agent, or may be a completely different person. And we need to stop assuming that, oh, if you have an emergency contact, or if you have somebody with power of attorney, that's the caregiver. Not always so, and we need to specifically have that represented in healthcare records according to that. It would be also very helpful for us to recognize that it's not just having the information available for a provider to call upon, but also it's a tool that would allow the family caregiver to actually report on day-to-day functioning of the person living with dementia, or to be able to update on functional and cognitive changes in the way the person that they are caring for is changing over time. It's a slightly different perspective on, yes, there's a role for having family caregivers identified in electronic health records so that they can better be included in a healthcare encounter. But we also know that EHR platforms have a lot of different population health management tools, which give us the ability to reach out to individuals of high risk or individuals of concern outside of that traditional encounter. Sometimes they're called registries, and there are various types of registries, but it allows us to start to identify how we can find individuals who would benefit from certain types of wraparound services, certain types of support services, and such. So we need to think of this as not only is this important at the time of a healthcare encounter, but if done correctly, it will open up opportunities for us to have better outreach directly to family caregivers, and even to think in terms of healthcare quality measures. For example, if a person is diagnosed with dementia, maybe we could say within 6 months, we should have somebody identified as the family caregiver in the electronic health record. Now that person can change over time, but wouldn't that make a difference of saying, we now know this person is in a situation in which they're likely to receive care from another person. Let's make that a quality indicator of our dementia care. And finally, I'm going to jump here a little bit, and there's some specific information about how we can do this. We've looked at it closely within our own system of where you can put information. There's a variety of places that it can be done. There are benefits that we can identify to going through them of where they're identified. Matching MRN numbers is important. If you're in a large integrated system, you can start to look at how the care of one is impacting another. And I just want to finish up here quickly and say, while we have not done as nearly as much as I would like to say as a system and getting caregiver identification, as much as we have wanted, and certainly we're continuing to work on this, but we have done major changes to individual localized changes to our EPIC system to support another major initiative of of our system, which was looking at the severe illness project, or sometimes called SICP. So and I use this as an example of it can be done if we line up the right support within the system, if we make the case and we make the investment. So this was a multi-year project that was focused on training as many of our primary care providers as possible and some specialty care providers, and how to conduct the serious illness project conversation so that we would better be able to start offering people palliative care services. And so really that, you know, the one of the 4 M's, what's meaningful to you, bringing that right out in front and putting it in a place of prominence. So we did major modifications to our EPIC system so that the basic questions that are used in the SICP conversation are right there in EPIC. And the button to get you there is at the top of the snapshot page. High real estate, high price real estate in electronic health records. But this project got it done and then got the questions in. And here's just one of the questions that involves discussions around families. And I use this as an example of a place where I think we have been successful at engaging families. We have been successful in adapting our EHR to implement a project. So my message, it can be done. I'm still working within our group, our healthcare group, to make this more of a priority. But I think the more conversations we have like we are today, the more perhaps we all can build the evidence and build the business case or build the value proposition, what have you, to not only get action at our local level, but take a message to the vendors of EHR and see if we can start having more about family caregiving uptake at the vendor level, which would make it easier on the local level. So I'll stop there. Thank you for the time today, and happy to answer any questions if we have time, Joe.
Great, thanks so much, Alan. Elma, are we answering questions after each presentation, or are we waiting till the end?
Yes, we were going to invite a couple of questions after.
Okay. So here's a question that came through the Q&A, Alan. Maybe you can address it. I think you kind of did a little bit through your talk, but it's an interesting point here by Mance. I hope that in the goal of person-centered care, we will begin to refer to those helping people living with dementia as care partners, driving the concern and wishes of the individual. I'd be curious to hear, Alan, your thoughts on that.
Yeah, it's a struggle to know what the nomenclature around this, you know, of when is somebody, you know, a care partner, caregiver, you know, I see value in both of them. You know, I think the harder leap is to go from husband, wife to either one of those titles, or child to either one of those titles. So it's working really at a one-on-one, understand the relationship and how the person who is providing care and support views themselves. And maybe that's the ultimate person-centered perspective we need to have, is working with an individual to see they may never want to be called either of those things and only want to be called husband and wife. So a great discussion item that I think needs a whole lot more discussion and work around, and really, you know, more from the ground, you know, from the grassroots efforts of what were different groups of individuals. I think there's also going to be some generational changes that we'll see, or some generational differences that we're likely to see in terms of how people relate to terminology.
Great. A comment here by Tiffany Robb in the chat. I wanted to bring this up. It wasn't sent in as a question, but a really interesting point. One I think you'll agree with too, Alan. My dream would be that the caregiver's EHR would be connected with the patients, since we need to make sure caregiver stress and health is okay to continue providing successful care to the person they are caring for.
Absolutely, absolutely. And that's the point of getting to a way of linking MRNs because medical record numbers. And I think that's meaningful in two places. It's meaningful in the delivery setting, because we often have caregivers tell us that, they express their concerns or their stresses to the provider of the person living with dementia, who is not their provider, and they get a bit of a pushback of, a physician not wanting to provide care to a person who's not officially their patient. Now, people can talk through that, but that does happen. So if we could make sure that we could do outreach to family caregivers who have an identification of a family caregiver in their MHR, MRN, then it's a little bit easier to do programs that are customized to caregivers that can occur outside of the caregiver, the health encounter with the person with dementia. On the other side, I think eventually payers would be interested in this idea of how do you really start to look, again, I'm going to be a little, aspirational here, but will we ever get to a point where payers look at this as a dyad, and the services they're providing to this dyad really has enormous differential benefit to the people in the dyad? So, but that again would require a lot of ability to connect people's health records, health utilizations, and really look at those kinds of family plan of care, family coverage. And I'm using that in a non-traditional way.
Great, Alan. Thank you so much for addressing that. Alan, I encourage you to, if you're willing to stick around, there are a couple that came through, I can direct you, or you can answer them directly via the chat tool. All right. Please feel free to do that, Alan. There were some good ones. And I would like to move on here. We have Juliana Valencia joining us here from Fairfax County Area Agency on Aging. She's going to present some information about an award-winning program that they've been implementing in Fairfax County that really excited to hear about. So please, Juliana, go ahead.
Hi, good afternoon. Thank you for having me here. I'm going to share my screen. Just give me one moment. There we are. So thank you so much. So for
Juliana, we're seeing your notes.
Okay.
You may want to go to the slideshow version. It looked good.
Let me see.
Yeah.
Not sure why that's happening, but is that better?
That looks good. Perfect.
Okay, good. Great. Thank you for your patience. So for us, it was very important to identify family caregivers because they span across all generations, and they are critical partners in providing care and support for a chronically ill, disabled, and or aging loved one. Unfortunately, we know that due to the demands of care for caregiving, their roles and all the responsibilities they take, research has shown that they become secondary patients and who are at a high risk for injury and adverse events. But specifically for us, there were two important reports that led us to increase our efforts in identifying family caregivers and implementing new approaches. So in July of 2017, the Department for Aging and Rehabilitative Services convened the Virginia Family Caregiver Stakeholder Work Group to study the issue of family caregiving and to draft recommendations for improving family caregiving supports and services in Virginia. Now, in 2018, this work group published those findings, and some of them were that 1 in 5 Virginians is a caregiver, and that 35% were adult children, 13% were spouses of the person they were caring for. And they also found that 50% was providing 8 hours of care each week, and 18% were providing over 40 hours of care each week. Now, then in 2019, Fairfax County conducted the 50+ community survey for Fairfax County and the cities of Falls Church and Fairfax City. We had over 4,000 people who participated in the survey. And that survey showed that 1 in 4 caregivers in Fairfax felt a level of physical, emotional, and financial burden. And despite feeling burden, 96% had not attended a caregiver support group. Now, having this data helped us understand the scope of the caregiving situation and really guided us in creating and implementing new approaches to address those diverse needs of our caregiving population. Now, our first approach was to diversify our communication methods. And what we did was really try to understand how people access information. We know that a lot of caregiving, for a lot of caregivers, really, it's very hard to have free time. And so a large portion of them are still working, they are raising families, and some of them don't really have time to access research information online to attend different type of events. And so we looked at all of our traditional outreach methods, such as our in-person presentations, in-person events, flyers, and we just realized that that was not going to reach to a lot of caregivers. So we had to come up with different methods, and I will talk about it later. So something also that we have been doing for many years now is collecting and analyzing quantitative data about our caregiver programs. So we survey each one of our caregiver webinars, classes, workshops, and panel conversations. And these help us understand how our programs are doing and whether or not we are meeting the needs of our population. It also informs our future programs, and it helps us include and incorporate topics that people want to learn about. Something very important that it also does, it helps us predict future outcomes. Now, collaboration and strategic partnerships are crucial to improving our capacity to serve our caregiver population, whether that is creating internal partnerships between colleagues or departments to larger partnerships between other organizations. We recognize that even though we have great programs, we don't really have infinite resources to serve our diverse caregiver needs. So we identify our gaps, and then we lean on our partners to create opportunities and to access new resources that in the long run are going to help us better support our caregivers. Often, family caregivers are not aware of their role, and they lack that knowledge of the services that are available to them. So having this partnership has enabled us to identify caregivers and implement new approaches to engage family caregivers in program participation. Now, as I mentioned earlier, that communication and outreach are really key in identifying caregivers and promoting access to different type of services, different type of programs. So during the last 2 years, we have worked very closely with our communications department, and that has been very, very helpful because it has allowed us to tap into the county's media platforms, which has given us the opportunity to reach a wider audience. We've been offering now monthly web letters. We have the Caregiver Alert Notifications program, which I will describe later. Then we also have a column in the Golden Gazette magazine, which goes to over 16,000 people. We also have access to the Facebook 50+ page through our department and the county's YouTube channel, which that has been very great in engaging family caregivers in the community. Now, under program development, we have been able to offer caregiver webinars, and we have been doing this for more than 5 years now. So during COVID, we didn't have to make any changes to our programs because we already had the platform in place. We had a model that was working, but what we did was to incorporate new topics that were meeting the needs of that moment. During the past year, we incorporated new workshops to teach self-care approaches, especially since a lot of people were home and they no longer had access to in-person events and programs. So we wanted to teach them self-care practices, skills specifically, that they could apply at home into in their day-to-day lives. We also added panel conversations that were has been actually very successful and have allowed us to incorporate a multidisciplinary approach to different caregiving topics. Now, I did talk a little bit about partnerships and why they are so important for us. And so some examples that we have about partnerships are interdepartmental partnerships. They have been very important because they have allowed us to create new programs. One of them has been the Caregiver Alert Notifications Program through the Office of Emergency Management. Then we have also partnered with different faith communities. Faith-based communities are a part of every community, and they have significant knowledge of the people they serve. They are great partners. They can that have really helped us bridge those cultural divisions, and also have provided connections to their communities, which at times, you know, they look at government employees as outsiders. So we have to be aware of that and develop those connections with them. Of course, it has taken several steps, but it has been very successful. In Fairfax, we have actually over 1,000 faith communities. So we work with the Interfaith Coordinator for the Faith Communities in Action, which is a network of faith community-based organizations and government agencies that work together to increase awareness of community services and resources and basically helping people access those services. Now, under healthcare systems, we know that navigating the healthcare system can be very overwhelming. So when we think about family caregivers, we really have to look at the intersectionality of the different roles they play, the many systems and professionals they interact with. For instance, family caregivers, you know, often accompany their loved ones to medical appointments. They often facilitate discharge, actually hospital discharge. They also help with and interact with home healthcare agencies. They interact with long-term care settings, with hospice services. So understanding these interactions, it really allowed us to look at the limitations and the barriers that many family caregivers have to face. And when we partner with the different healthcare systems, we can better address their needs and their priorities, the family's needs and priorities. So currently, we have a partnership with one of the largest healthcare systems in Northern Virginia, and that's ElderLink, which is a nonprofit partnership between Innova Health System and the Fairfax Area Agency on Aging. And this partnership enables us to promote the well-being, the safety, and the independence of older adults and family caregivers. And it has also enabled us to provide services to people who are right in the middle, people who don't qualify for income-based programs or don't make enough money to pay for private services. Now, through this partnership, we have been able to offer case management, in-home services, geriatric care consults, bathing services, respite services, and many other programs. Now, it has also been very important for us to partner with hospices such as Capital Care and Health and Blue Ridge Hospice, and that was to offer different educational programs for family caregivers. Now, in addition to that, it's very important for us to recognize the role of home health agencies in providing care in the community, because they are direct providers of care and can also be great partners when identifying family caregivers and really helping connect those family caregivers to county programs. Now, other key partners have been support group facilitators. and also other organizations that have improved our capacity to serve caregivers have been the Alzheimer's Association, Insight Memory Care Center, the North Virginia Dementia Care Consortium. We have been able to create educational programs through those partnerships. We have been able to offer an annual caregivers conference that seeks to prepare family caregivers in providing care and support at home, to help them learn new ways to engage individuals with dementia and to learn about new supportive services. Also, since 2019, we have been participating in the Dementia-Friendly Fairfax initiative, which is the result of a partnership between nonprofit organizations, the Fairfax Commission on Aging and the Fairfax Area Agency on Aging. Initially, this initiative focused on providing training to neighborhood villages, local libraries, and community volunteer ambassadors who work with older adults. But currently, we are offering these training sessions to the community at large, really anyone who wants to learn more about dementia and how to support their loved ones and their family caregivers. Now, under innovative approaches, I would like to talk a little bit more about the Fairfax Caregiver Alert programs, which was recently one of the recipients of the National Association of Area Agencies on Aging under the caregiver category. So this program has enabled family caregivers to remain informed, obtain education, and easily access programs and services that are offered by Fairfax Area Agency on Aging and other county departments. They access this information via text messages, via emails, or different voice communication methods. Now, to access these services, the caregiver has to subscribe to the Fairfax Area Agency on Aging Caregivers option through the Fairfax Alert system. And once they do that, they start receiving weekly notifications with information about workshops, webinars, supportive services, and many other programs. The purpose of this program is to provide caregivers and their loved ones with an educational tool to build awareness and easy access to available supportive services. And that in turn helps reduce caregiver stress and improve quality of life. So basically the information comes to them. They don't have to research or figure out what's available in the county. Now, this is a partnership program between the Fairfax Area Agency on Aging and the Fairfax Office of Emergency Management. The Fairfax Alert system is a free service, and it has been offered by the Fairfax Office of Emergency Management. And basically what it does is it sends out information to its residents about emergencies, life and death situations. But we recognize that the alert system has transformed the way the county has reached out to the community, and so also we recognize that it could be utilized for more than just emergency alerts. So in September of 2019, we approached the Office of Emergency Management to collaborate with them with the purpose to utilize the alert system as an educational tool to support family caregivers. Now, this new program didn't require any additional expense to either partner because it is using existing resources. There was no need to purchase or develop a new software. The Fairfax Alert system has been in place since 2014. And we didn't have to hire new staff or allocate a budget line to develop or implement the program. And since the program began in 2019, we have tracked a rapid increase in program participation, as well as access to the caregiver telephone support call, referrals to the Aging, Disability, and Caregiver Resource Line. We have actually tracked a 73% increase in program participation in our caregiver webinars, our health and wellness workshops, and panel conversations. And currently, this program is serving over 800 family caregivers. And since the pandemic began, the program has helped to share information aimed to prevent and mitigate the virus, as well as support and inform caregivers about the local pandemic response efforts, in addition to providing information about different programs and services to family caregivers. Now, under future opportunities, for us, it is very important to understand equity, diversity, and inclusion within family caregiving. Although many family caregivers might share similar experiences in providing care to a loved one, there are also a wide range of differences that are influenced by their diverse backgrounds, such as gender, age, culture, and that is just to name a few. So it is important to understand those differences and to know how they influence a caregiving experience. We know that caregiving has been happening since the beginning of humanity, and in a way or another, our society has relied on family caregivers to kind of provide support for their loved ones. We really need to look within our own systems and examine how they might contribute to gender inequality, especially when we have, as a society, conferred the role of caregiving to women. We have to look at how that puts women at a disadvantage. Likewise, we need to look at how male caregiving plays a significant role in our community, and they are rarely acknowledged by their community. So understanding these differences, it's going to help us identify caregivers, it's going to help us prevent the structural barriers to access services, and it is also going to promote collaboration between the service providers and the family caregivers. So another important aspect is applying strategic planning to program development. Looking at national and state data are very important steps in program development. We also really need to look at our own jurisdiction, because we have to understand those differences between caregivers who are living in rural areas versus urban areas. And so assessing their needs is really going to help us come up with goals and objectives that are going to meet those priorities. And that along that comes the targeted outreach, which I talked about it earlier. Currently, we are actually embarking the help of our department, of our quality assurance department, to develop a tool to access the needs or to assess the needs of our family caregivers in Fairfax. And that's going to be kind of a long study that we are going to do to help us with future planning of different programs. And so that concludes my presentation. Thank you so much for listening.
That was wonderful, Juliana. Thank you. Congratulations on the tremendous work you're doing at Fairfax County. I'm looking at a lot of the comments in the chat. People are very excited with the work you're doing, so thank you. I think in the interest of time, we should move on here. Our next presenter is Kristen Griffis. She will be, again, presenting some really exciting work of partnering of a local AAA with healthcare organization as it relates to caregiving. And I'm going to turn it over to you, Kristen. Thank you.
All right, wonderful. Thank you. Let me share my screen real quick. And let's see. All right. And hope everyone can see that.
Looks great. Thanks, Kristen.
All right, wonderful. Okay, so I'm going to talk a little bit about a program that we have here at the Area Agency on Aging, Elder Options. We're in the greater Gainesville area, so North Central Florida. And it actually started under a grant from CMS under the Innovations Grant for the Community Care Transition Program. At the time, they were called CCTP grants that were given to social service organizations and hospital partners to help with readmission rates, 30-day readmission rates for certain Medicare penalty patients. And so we started that program back in, it was 2014, I think, or I think around 2012, I think it was actually. And we worked with two of our health systems, University of Florida Health System and North Florida Regional Medical Center here in Gainesville. When the federal funding sunsetted and went away, the University of Florida Health System had found a lot of benefit in the program and continued to fund it and has still funding it today. So, but we've added a caregiver component, identification and assessment component, and that's what I'll talk about today. So I'll just talk a little bit about some of the unique characteristics. Again, it was originally a care transition program. So we started with, we used the evidence-based care transition intervention. It's called, some people hear it as called the Coleman model. We were trained on that. We had community health workers who were trained, and we would be doing transitions, from home. So hospital to home transitions through that program. And one of the things we really found as we started that program, a year or two into it, was that it was really important to make sure the caregiver was identified and included when we were doing the transition. So we started to work with the University of Florida Health System, and together we, collaboratively target and identify caregivers. And when we did that, we decided that we were going to look into other evidence-based programs and services that could be attached that would allow to better support of these caregivers as we identified them. So one of the software or interventions we started was called T-Care. It's called Tailored Care Assessment and Referral System. And it's an assessment system that we put caregivers through. So once the caregiver is identified, we will then schedule a T-Care assessment with one of our community health workers that's also trained in the Coleman model. So they will do the T-Care assessment, and within that T-Care assessment, we take a look at it assesses and targets stressors that caregivers are having in their life, and then it helps us to develop some care plan with goals and able to connect them to local resources. So we work with caregivers that way, and then we also started our Savvy Caregiver program, and it's an education-based, evidence-based program. Where it's like a training course. It helps caregivers caring with individuals with dementia to, understand the caregiving role, understand the disease, the progression, the journey, gives them knowledge and skills. So we can then, once they've done the assessment, if we need to, we can connect them to the Savvy Caregiver program. And then we also have an evidence-based depression management program called PEARLS that we have community health workers trained in also. So whether we can do a depression screen and find out if the caregiver is having mild to moderate depression or the patient, when we can then connect them with a PEARLS coach, and that coach will work one-on-one with the individual, the caregiver, to over a 6-month period of time. And they develop goals, helping them to get back to seeking more pleasure, pleasure activities, things that they may enjoy that they haven't been doing, and really trying to help with the mild to moderate depression. So we think this is a really great package. It's wonderful so that we can identify the caregiver, we can have all these supports, and it's really, as the next bullet I said, it really gives patient and caregiver empowerment. We think it's very important. In this, usually you're when you're in the hospital, when we find them in the setting, they've gone through an acute care crisis, or they're just acute care incident, and so now there's a lot going on, and lots of times a lot of new training and education needs for the caregiver, and we really believe in patient and caregiver empowerment. We do have multiple healthcare partners across the setting, so we work very, very closely now with the hospital and the hospital staff, but also with the home health agency that's attached to the hospital. We work very closely with them and other post-acute providers that we meet with on an ongoing basis to try to find ways we can improve our processes, the way that we can kind of streamline and make the system more friendly for the caregiver and the patient. We realize with this all, again, is a big communication. We do have communication through the emergency medical record. They do use Epic. So we are able to use that as a communication tool. And it's really helped us, really have better timely interactions at certain transition points. So the importance of including caregiver identification for us, we just really believe in, and as we all know, everybody on this call, I know caregivers are overburdened. They usually are caring, their physical care, they're taking care of their symptom management, emotional support, and helping with activities of daily living. So there's a lot going on with these caregivers there, and they're usually, when we're, like I said, in the hospital setting, they're transitioning home. That it's a really stressful time for caregivers, so extra stress than normal. So we think it's important that we're there at that time. We believe it saves costs. I mean, obviously, we're able to get the care more timely, and that improves the caregiver. We can improve the caregiver's quality of life by giving them these supports and access to these things like T-Care and Savvy and Savvy Caregiver. We definitely see improved compliance with patients' treatment plans when caregivers are identified and empowered. That makes sense. You know, the caregiver is a critical part of the care team, and really, you know, the compliance with medications and the treatment plan is much better. And of course, number one, caregivers are crucial to the overall success of long-term care. Our long-term care system, it's total, the total amount of uncompensated care is just mind-boggling sometimes what they do. And I know everybody knows this and is feeling it. We all are. The direct care workforce shortage right now is really concerning. We really don't have the capacity to care for the people we need to. And so these caregivers are even more important now than ever to continue to be able to support them so they can provide the care as long as possible. We need them to provide that. And again, just some more benefits. And I know for the interest of time, I don't want to go over too much more, but just identifying the training needs for caregivers. It's really important lots of times when they're transitioning back to a home that there's new training needs for the caregiver that we can connect them up with. So we think that's important. And then of course, just the increased awareness of linkages to social supports. As I said, better coordination of care. We definitely see better health outcomes for the patient and the caregiver. And then we really think it's good for our healthcare partners. They've really, in the post-acute providers we work with, that we brought this really, the caregiver up to the, you know, elevated the caregiver and the importance and the need to support the caregivers. And so it's really helped with our healthcare partners to better understand the roles of caregivers and the challenges facing the patient. And then another big one is obviously improved communication to the hospital and to the medical providers when the patient after discharge. So we're able to work with the patients and the caregivers and really have that ability to get the information back. And so you have that cycle of communication. So that's it. That's all I've got. Just a really quick overview of what we're doing here at Elder Options. And I want to thank you all for the opportunity today to kind of talk about what we're doing. And I'll turn it back over to you.
This is wonderful, Kristen. Thank you so much. Again, both of these programs doing such exciting things. And, you know, again, I think it probably echoes and parallels what many of you might be doing as well, just getting that sense from reading the chat here and everything. What I'd like to do is turn it over to Drs. Chodosh and Dr. Borson. For the remainder of our time, we're going to hear them react to what they've heard, provide some comments and insights themselves. And then if we have time, maybe we can go through some of these questions that have been posed by the audience, which again are really, really interesting and important. So Josh and Sue, please.
Sure. Well, let me start because I have something to react to, which is, I think, certainly of personal interest to me. So first of all, I want to thank all the speakers for just wonderful presentations and for talking on such an important topic. For those of you who don't know me, I am a geriatrician as a clinician, as well as a health services researcher, and certainly along with Dr. Borson, have known Joe for quite a long time and have really enjoyed our collaborations. One of the things that has struck me just listening to this, and these are really wonderful programs that you're talking about, is this issue of identification. And I'm speaking now as a physician and as my own clinical experience, both in the outpatient world, but also in the hospital world, where I probably spend an equivalent amount of time, that when there's urgency, as in an acute care setting, identifying this, and I do prefer the term of care partner, but identifying this person who is going to help the patient themselves is a fair bit easier, or there's almost like it's not something one has to think about. Oh, I forgot who is this other person who might be helping this person at the time of either during their hospitalization, so we have better information, and perhaps equally as importantly at the time of discharge. In the ambulatory setting, it's a horse of a different color. I think it's a really different matter, and it's a much more difficult one. So I think as much as having systems like Epic set up in a way, and that was a wonderful example that was presented earlier, where people are prompted, I think, and Sue and I talk about this a lot, these conversations, but where people are prompted to ask the right questions and to then record what will hopefully then be very useful information. I think the challenge for me thinking about this is, how do we build this into our ambulatory healthcare system so that we're sure that these are individuals that are included in the mix? And obviously we can spend a lot of time, I think, talking about what that negotiation looks like, because I think we can't forget that there is this person who is the patient, and I'm always very concerned about raising the level of their personal agency, their personhood, their independence to the degree that they are able to be independent in their own care and make their own decisions. So this to me is a little bit of a dilemma when we think about more acute care settings versus if you'll have it, less acute care settings, as we might see in a clinic or in a physician's office. So let me stop there.
Good morning, everybody. Good morning from the West Coast. Thank you, Josh. I've been musing over this. I'm so impressed with what everybody has been doing and trying to fix problems, that I want to highlight that the fact that we created a lot of the problems that we're facing now. By we, I'm talking about the development of and reliance on technology and large healthcare systems and rapid appointments and efficiency. And mention a story from my own childhood. I'm the child of physicians. I am a physician myself. And when I was a little girl, my dad would take me on rounds on Saturday morning. These rounds were at home. He did his home visits on Saturday mornings. And I would mostly sit in the car for privacy of the patient, but sometimes I'd be invited into the home and for lunch with my dad, with the patient, usually a very old person, often with a dementia, but who knew at the time. I certainly didn't. And a family member who had produced a very nice lunch for us in compensation for my father's home visit. Now, that was a time that most people on this call can't remember because you're too young. And many people wouldn't have had the opportunity I did to spend time in patients' homes with a physician who understood what it was to care for somebody who was on a downhill trajectory. So we're trying to get back to that through the use of technology, that kind of feeling, I think, because we've created circumstances in which it's very hard to generate that feeling of care for our patients, our families, and for ourselves in the institutions where we work. So we're all shooting for that same kind of outcome, which is a much more personalized version of care than where we've all been over these last several decades. So that's just a little piece of perspective. The other thing I wanted to bring up is the challenge of our language. This was touched on before, the care partner versus caregiver, but I'm not that. I'm a wife, I'm a husband, I'm a son, a daughter, a mother in the case of a caregiver for a child with a disability. So those roles, as I used to talk with caregivers in my practice, my dementia care practice, at University of Washington, about the fact that they're actually, they are running on two parallel tracks. One track is the track of their longtime relationship with the person that they're caring for now. But the other is a professionalized track where they have to learn skills that are not part of being a husband, a wife, a daughter, a son, a mother, a child, etc. They're clinical skills, really, that are required of caregivers in the home to translate healthcare designs and requirements that doctors, nurses, and others produce. You have to do that at home if you are the care partner or the caregiver. You are an unpaid healthcare worker in the home. And that's the piece that I think deserves some additional attention than what we've been giving it in our research. It's certainly something very interesting to me, something that I've tried to tackle in a somewhat more feeble way than I wish, I would say. But those parallel tracks are part of what makes this so tough. And the only way we're going to join those tracks, put the railroad ties across the two, is going to be through technology and through figuring out how to make this feel like those old home visits in our patients' homes when I was 5. So I'm inspired by what everybody's been saying today, that we're actually on the path to getting there, as long as we remember that that's where we're going. Technology is our servant, and too often it's been our master.
That words never spoken more truly as a physician, and for most physicians. But that raises a really important point, right? We think, most of the business here is in the primary care setting, and primary care physicians will tell you, what do you want me to do now? I mean, that might be their response, and in part because they are under resourced often. They do feel overwhelmed, and they never feel like they have enough time because they have many boxes to check, which is never satisfying. If it's viewed that way, certainly is never satisfying for a physician. It's not satisfying for patients or families either. I think a lot of what we're talking about here is also about culture and kind of digging into, what does it mean to help another person? What does it mean for the person who's helping? And what does it mean for the person who's receiving that help? I do think that certainly, I mean, I love the fact that Joe, that you have this center. I think you are the person to have it, and all the work that you've done over the years. And I think that your center and the other things like this webinar that it's doing is raising awareness, but even more than just raising awareness. It's if you talk about these things enough, they become more a part of the conversation. And I think to that degree, from speaking now as a physician, as things are more face forward or in front of me, it becomes more commonplace, more, okay, yeah, this is part of what I do on a regular basis. You, at least in some practices now, having a very quick, 2-item question, the PHQ-2 for depression, is a routine part of medical practice. It's certainly throughout the VA system, it's mandated, but it's something that just becomes a regular part of one's history, if you will. And depression, talking about mood, I mean, for years back and not too far back, that was really, for many folks, I think, kind of taboo, kind of an area that you wouldn't want to get into because you wouldn't necessarily know what to do with it. And again, I think as we raise the level of importance of caregiving and making sure we know who our care partners are, I think then we're in the space where we begin to talk about some of these more important cultural nuances and sensitivities, and the opportunity to avoid perhaps being offensive, but also being very inclusive. And then from a medical care standpoint, there is this other tremendous issue and very challenging one that we don't train our medical providers at any level to do, is how do I manage this in the moment? How do I manage the visit when I have the patient that I'm providing care for and this other person, often a family member, who is also serving in the role of the partner? Who do I talk to when? How do I talk to them together? All of these things are now starting to rise to the level of discussion, even research through the National Institute on Aging, and are incredibly important. So I think I feel very optimistic because I think we're on our way, but we have to continue to have events like the one you've put on today, Joe, and the wonderful work that people are doing, both presenters and I'm sure some of the people who aren't presenting today but are here amongst us as attendees.
One point came up in the chat. I wanted us to talk about it because it has a lot of relevance, if not for our center, I think for your center, Josh and Sue. And it's from Sharon Hall, and it resonated with me. And she was mentioning in the chat that, she goes to all of these webinars and no one really talks about this increasingly prevalent phenomenon of people, Sharon used the term young onset dementia, but I would argue it is this phenomenon of, as specialists are able to diagnose people sooner and sooner, and in fact, might be incentivized to do that for some reasons, we're going to see more and more people with this diagnosis of Alzheimer's disease or other related dementias at the ages of in their 50s, maybe even younger. And what does that mean for our work? What does that mean for what we're doing? And I'd love to hear from you, Josh and Sue, what you think about that.
Well, maybe I'll just say a couple of things, and then I also want to hear from Sue, and I always learn from Sue. I think that what we're really talking about is, yes, there's the diagnosis and the incredible weight that such a diagnosis might have. But for me, it's really about, where is this person at right now? There are many people who have the diagnosis and the condition that we would all call, meets criteria for a dementia condition, who are not overly dependent on another person. And certainly if you are, in the current day, we have 50% of people who are even in the moderate stages of a dementing illness who are not being recognized and therefore not being diagnosed, maybe being recognized but not being diagnosed. And certainly as we do a better job of this, as you say, Joe, we are going to find people in quote unquote earlier stages. But that also means that we're going to be finding people who may be having some difficulty with one or another kinds of tasks, but they're still, very productive, contributing members of their community and their families, and will likely be so for many years to come. And so this whole notion, I think it's also perhaps why I think this terminology is so important. That what is my role with my father if he's received such a diagnosis, but he's still directing me in terms of telling me how to do certain things that I don't know how to do, because he knows how to do them better, and making decisions about his life, and probably good ones.
One question came for you directly, Sue, in the chat, and I can look for this too. Came from Martha. It's, do you have any evidence or reports pointing to the potential of technology to improve the role of caregivers of persons living with dementia? I can weigh in on this too, but I'd like to hear from you, Sue, first.
So first, I have to say that my internet is so unstable. I've been joining and rejoining, so I'm missing some of the content. I wanted to comment first, though, on something on what that previous question about younger people, and just remind everybody that young onset dementias, the degenerative dementias with young onset, can occur as early as I know this is going to sound way off base.
Oh, shoot.
Yeah, we're unfortunately losing Sue there. Hopefully she can come back and comment. But I'm going to address this question related to the technology and do we have evidence that they can support dementia caregivers? That's a good question. We're doing some work now. We're disseminating it. We evaluated a remote activity monitoring system for people living with dementia at home as well as their caregivers. The findings, I would say, are fairly mixed. They have some promise. But when you take a step back and look at the technology literature in terms of research and dementia, basically technologies are broadly approached in these studies in two ways. One, as kind of advanced real-time data collection tools, and then as standalone interventions. So I'm going to address more the latter as far as, does technology actually work as a standalone intervention? I think the answer would be is the science, unfortunately, as it is in many areas of dementia care innovation, is evolving. Much of the work has really focused on feasibility, usability. Do these technologies, does it seem like people accept these things okay? When you actually look at evaluations of effectiveness, there are far fewer of them out there. So for example, like with remote activity monitoring, which are these home-based sensor systems, you see these out there a lot, and Alan will weigh in here too, great Alan, is there was a really large scale study that took place in the UK called Attila, didn't show any evidence on really any outcome at all. was a randomized controlled trial. Our randomized control evaluation, we showed evidence for caregivers over a 6-month period. And I'm going to qualify that in that it was kind of a complex moderational effect over 18 months. And that was a benefit of our study. We followed people over a year and a half, didn't see anything. However, and we're about to disseminate this, the system did seem to have an effect, kind of shockingly, on emergency room visits and falls. And the issue is, and we're trying, you know, I'm doing my best to write this up, is why? You know, if it didn't have any effect really on any of the caregiving variables, there were some other things maybe happening. And I don't want to put too much stock in that type of evidence. The third area where technology, I think, is important, and you see this alluded to a little bit in our chat here today as well, is as a platform to better disseminate existing evidence-based interventions. For example, delivering via telehealth or other more novel ways over the internet, intervention protocols that have shown effectiveness, like REACH, other types of protocols, vis-a-vis these more advanced technology approaches as well. I think that particular strategy will bear fruit. And I'll stop there because I'd love to hear what Alan has to say. Oh, you're muted, Alan.
I agree with your last comment. I think the idea of having technology as a resource to remove some of the barriers of dissemination and making things more available to caregivers, I do think there's potential there, and that will only grow. Related to the censor issue, I'm not directly involved, but I sit on the advisory committee for some work being done here in Texas, funded by the NIA out of a very large SBIR, or I always get that wrong, to a group called Berkland Current. And it's the most impressive approach, and they're working a lot with the people at Georgia Tech. The most impressive approach I have seen of linking sensory data and tagging sensory data to ADL functioning and changes in ADL functioning. And it's early on, and they're just showing really approving the concept of this as a measure of ADL functioning. But and I'm sure there are many others that will have similar stories. But I think my point is, I think that the technology will only get better in terms of sensors and how sensors can become maybe not a standalone, but an additional measure of function.
Yeah.
So,
and with all of these, oh, go ahead, Josh, please.
no, I was just going to say, I think we have to be really careful. It's a very complicated discussion. What kind of technology and technology for what? And Joe, you alluded to that a little bit. But I also think we have to worry a bit about what else are we asking these individuals in this role of caregiving to do? And I can tell you that in the VA system, when this was tried as a way of monitoring, because caregivers would then report on a daily or weekly basis through a set of questions that they would then answer. It was pretty disastrous, actually. I mean, it was in the sense that people didn't want to do this. They felt very burdened by this. I will say, from the standpoint of video technology, I think we don't really have much in the way of reports yet, but I think we're going to see some change in perhaps caregiving stress, as well as loneliness because of the isolating factors, where one then has much greater ability to connect with others and connect in a visual way, literally, that they would not have been able to connect otherwise. And I think that may well have some very important benefits.
Yeah, and I think, really interesting point here made by Rebecca Hahn in the chat is technology is helpful, although not all people can afford to have the latest and greatest electronics. You hit on a really key point, Rebecca, and I hear this from technology development, in Minneapolis, St. Paul, as there are in some other cities, a number of technology companies, engineering companies, they want to create the new shiny object, get it to market to sell, right? And you'd be shocked. They want to develop these technologies for people living with dementia. And after meeting with them for 10 minutes, it's fairly evident they have no idea what dementia is, what it's like, what the lived experience is, how people, families care for people living with dementia. And why it's relevant to your question, I think, is unless technology development, and it's also another point that was made in chat earlier too, effectively incorporates people living with dementia and caregivers in the design of the technology, and then is able to embed it seamlessly with day-to-day existing technologies like a television. Not about, I'm going to buy this big system, I'm going to make a smart home, and we're going to have a sensor in the wall and the ceiling. Not those kind of things, but are there ways to embed it within existing technologies that older people use every day? I think in the end, that's the answer. And Josh, I'll leave the last point to you.
And in fact, Joe, people have done that. So you're unless you're thinking about that, you are brilliant too, because this is something that has come out of not going to be an advertiser here, but come out of a large TV company. It's disseminated through a number of large assisted living facilities. I don't really know where that particular program is at, but it completely integrates at least communication technologies into television, and with a very simple clicker device, so that people don't have to. I mean, I think lots of us get confused with one of the 20 button handheld devices, but so I think there are lots and lots of opportunities for this, and it's just one small piece to this puzzle to continuing to improve identifying caregivers and then to be able to then follow that identification with meaningful interventions.
Wonderful, Josh. Thank you. Very compelling final point for our exciting webinar today. So many great ideas. I guess I have the benefit of not presenting like some of you, in that I can see and read all the chats alongside the great content provided. As we shared with all of you and the attendees, we will be emailing you the slides, the recording, and then also the chat as well. I mean, the chat itself had a lot of great questions and comments and ideas that, again, we want to share with everybody. So in addition to Alma emailing that out to you, this will also be available on our website, bolddementiacaregiving.org. I encourage you to view that and then also see some of the other great material and resources we have available for you there. Follow us on Twitter as well at @Pico_DC if you have a chance. Alma is going to be providing a link to the evaluation in the chat. Please do take time to fill this out for us. It's very helpful to us regarding this webinar. Alma will also be emailing this link out to you too. Otherwise, thank you for being part of this great webinar. Thank you to the wonderful speakers, Dr. Stevens, Dr. Borison, Dr. Chodosh, Juliana, Kristen, Ms. Valencia, Ms. Griffis. Again, thank you for being part of this great presentation. We look forward to working with all of you in the future. Have a great end of the year, and we hope to hear from you soon. Thanks, everybody.
Thank
you, Joe.
Bye now.
Bye-bye.
Thank you.